Hello, in this section I will talk about myocardial protection. Now, myocardium possesses innate or natural capability to protect against ischemic injury, and this natural capability of myocardium is something which can be induced by certain ways like ischemic preconditioning, ischemic postconditioning, or remote conditioning. And there are other ways of myocardial protections as well, like your stunned myocardium going in stunning, that is stunned myocardium, or going in hibernation myocardium, or developing collaterals to manage the period of decreased blood flow through giving the heart tissues blood through these collaterals, by developing these collaterals. So there are a number of ways by which the protect myocardium tries to protect itself from ischemic injury, and that is all what we are going to discuss in this section. What are the ways of myocardial protection? Then we will also discuss about the pathogenesis or pathophysiology behind this. What are the mediators, right? So, and what does the evidence-based medicine suggests on this? Because this is still a concept which is in evolution. Okay, so as I said, that the myocardium possess innate physiological adaptive process which renders it more resistant to ischemic injury, more resistant to ischemic injury. So what are these ways of protection? What are these adaptive process? Now, the most defined one is something called ischemic preconditioning. So what is this ischemic preconditioning? Now, ischemic preconditioning is the brief period of sublethal dose of ischemia given to the myocardium before the real ischemia it faces. So, preceding brief periods of sublethal ischemia, right? Separated by, that is preceding brief period of sublethal ischemia, separated by period of reperfusion. Now, this ischemic preconditioning is practiced before the real ischemic insult happens to the patient. Then we have something called ischemic postconditioning. Now, what is this ischemic postconditioning? Now, this refers to series of brief occlusion of the coronary arteries after the period of insult. So, this refers to the postconditioning refers to series of brief occlusion of coronary artery after severe ischemic insult. Then we have something called remote ischemic preconditioning, which has been demonstrated in animal studies. Human cases yet to be more studied. Remote ischemic preconditioning. So, remote ischemic preconditioning. So, these are the three ways which has been defined. Apart from this, the other measures are of myocardial protection. The other measures are your myocardial stunning, your myocardial hibernation, and development of collaterals, collateral circulation, right? So these are other measures of myocardial protection. So let us first start our discussion that what does this ischemic preconditioning offers? Why we go for this ischemic preconditioning? Why it is so much being studied for myocardial protection? That how does it make it more resistant to ischemic injury? What does it offer? So ischemic preconditioning, it is offering us protection by several mechanisms. So it enhances the tolerance of the cell to the lethal injury. So myocardial cell in prior, when it is exposed to the sublethal dose of ischemia, it protects against the lethal dose of ischemia which is it about to tolerate. So it makes it prepared for that lethal injury. So enhanced tolerance. Number one, it causes enhanced tolerance to lethal cell injury. Tolerance to lethal cell injury. Then it protects against the endpoints of ischemic reperfusion injury, like it protects against the ventricular arrhythmias, right? So it protects against other endpoints of ischemic reperfusion injury. So we have what are the endpoints of ischemic reperfusion injury, which it protects against contractile dysfunction of the myocardium, the arrhythmias which can appear. So it protects against contractile dysfunction. It protects against the ventricular arrhythmias, and it also protects against the apoptosis which can develop. So it also, apoptosis we all know is one of the mechanism of cell death. So protects against apoptosis. So these are the important things which the ischemic preconditioning offers, and this is how it protects against the lethal myocardial injury during the ischemia. So what is the time it lasts for? Now, whenever this ischemic preconditioning is practiced, we have an early protection phase and we have a late protection phase, a second protection window, what we call it. So it has it gives us immediate protection, which lasts for 1 to 2 hours. So it provides immediate protection, that is first one, and this will last for 1 to 2 hours. And then we get something called delayed protection, which lasts for 72 hours. And this delayed protection appears at 12 to 24 hours, right? This delayed protection is called second window of protection. And this, as I said, it lasts for 72 hours. Imagine it is lasting for 72 hours. Okay. So what is the duration of ischemic preconditioning? For how long the ischemic sublethal dose of ischemic insult should be given? Now, number of duration has been studied. What has been found, 3 to 10 minutes has been studied of brief period of ischemia myocardium is exposed to. The maximum benefit is at 10 minutes. Beyond 10 minutes, there is a possibility of irreversible damage. So beyond 10 minutes, no further protection, but damage can happen. So it is not practiced beyond 10 minutes. So 3 to 10 minutes periods has been studied in various studies. And what has been found by evidence-based medicine, 10 minutes gives maximum benefit. So it is suggested to go for 10 minutes by most of this evidence-based medicine. Okay, then what is the mediators? How does this ischemic preconditioning, when this heart muscle is subjected to sublethal dose of ischemia, how does it protects against, what are the signaling pathway. So pathogenesis is not completely elucidated, it is not completely clear, it is not crystal clear, not completely elucidated, but various models of preconditioning suggest involvement of number of mediators like your adenosine, which we will discuss what is the role of adenosine, then acetylcholine, then your catecholamines has been implicated, then your angiotensin 2 has been described, bradykinin, then your endothelin, some opioid receptors has been implicated, and reactive oxygen species, reactive O2 species. So these has been elucidated as the mediators for protecting against this ischemic injury. So this is the model that during ischemic preconditioning or even during ischemic postconditioning, the mediators are same. Now, number of mediators are released which interact on the myocardial cell through G protein coupled receptor. Here we will talk about the most important G protein coupled receptor which acts on it. Then it activates number of pathway and number of intermediate mediators like the nitric oxide, your PKG, etc., which acts on a channel present in the myocardium, MPTP channel, which we'll talk about. This MPTP channel gets closed by these mediators. This channel is responsible for most of the detrimental cause of ischemic injury, right? So when this channel gets closed, we have a better ATP level, we have less acidosis on reperfusion, and less calcium loading, less calcium release is seen. So all this causes up cardioprotection. So one by one we will see the role of these signals, So how does adenosine act? We all know adenosine is a byproduct of the adenosine triphosphate. Adenosine is an endogenous compound which is formed by the breakdown of adenosine triphosphate in myocytes during period of ischemia, and this has been consistently shown as a mediator for ischemic preconditioning in most animal species, including the human studies which has been done. Now, what studies have shown that an inability to produce adenosine, right, endogenously, this results in refractoriness of the myocardium from this innate protection, refractoriness of myocardium to ischemic preconditioning. And this ischemic preconditioning can be stimulated if adenosine A1 receptor, or by stimulation of adenosine A1 receptor by exogenously administered agonist, right, which acts on this adenosine A1 receptor. So endogenous, what studies have shown that if endogenous adenosine production is not happening, the patient is resistant to ischemic preconditioning, and if we give exogenous adenosine, the ischemic preconditioning can be reinforced. So role of adenosine is well established in ischemic preconditioning. The myocardium can be maintained in a preconditioned state against ischemic reperfusion by repeated activation of adenosine A1 receptor over the period of 10 days without the development of tachyphylaxis. So it has a great role in this innate ischemic preconditioning. Okay, then we have, where does this receptor act? The adenosine plus the other mediators like bradykinin or opioids or endothelin or angiotensin or norepinephrine, all this acts through this protein kinase C. Now, adenosine, norepinephrine, acetylcholine, they are coupled with this inhibitory G protein receptors. It has been proposed that activation of these GI protein coupled receptor by various ligands results in activation of number of kinase cascade at the center of which lies protein kinase C. So number of kinase cascade is activated. Even the tyrosine kinase, but the most important kinase is your protein kinase C. So this is the most important kinase, protein kinase C. We have to keep in mind. Now, it is likely that other protein kinase also are activated in parallel, but main is protein kinase C. So activation of other kinase like tyrosine protein kinase may be crucial step in signaling cascade. Protein kinase A also been implicated. The relative position of protein kinase C, tyrosine kinase and other kinase in signal transduction pathway of ischemic preconditioning is still under investigation. So this is still under investigation, but most of the studies have found that main is protein kinase C. It lies in the center, right? Okay. Then ATP dependent protein potassium channels again has a great role. So ATP dependent potassium channels, that is KATP, appears to be involved in metabolic adaptation to ischemia during preconditioning. There is evidence that mitochondrial KATP channels rather than surface sarcolemmal KATP channels are likely factors. So we are causing the difference at the level of myocardium, which is responsible for these ischemic injuries. Opening of these channels results in repolarization current, and that reduces the duration of cardiac action potential, leading to reduced calcium entry into myocyte. Calcium has been implicated as the main cause of this ischemic reperfusion injury. So this opening of these channels decreases the duration of the action potential and decreases the release of calcium inside the cell. This results in cardiac workload and enhancement of myocardial viability and a reduction in cardiac sympathetic nerve injury. So role of ATP dependent potassium channel has huge. If I show you the image, the ATP dependent potassium channel which acts at the level of myocardium. Now we have at the level of sarcolemmal also, but mostly at the level of myocardium it is giving its benefits. Okay, then we have something called opioid receptors. The activation of the delta opioid receptor within the cardiac myocytes triggers ischemic preconditioning in animal models and in human atrial tissue as well. It has been shown. The opioid receptors are coupled with the G proteins and activate protein kinase C and mitochondrial KATP channels. So both that mitochondrial KATP channels and the protein kinase C is activated by the opioid receptors. Then reactive auxin species. Mitochondrial production of reactive auxin species prior to the index of ischemic period acts as a mediator of preconditioning signal through activation of various protein kinase channels such as protein kinase C and other X also. Then pro-survival kinase, new kinases which develops, the pro-survival kinase. Signaling through the pro-survival, the phosphatidylionestol 3-hydroxyl kinase, that is PI3K, and AKT cascade during preconditioning phase appears to contribute a protective effect of ischemic preconditioning. This is under current study phase, that what are these pro-survival kinase. Signaling through these pathways results in activation of endothelial nitric oxide synthetase, opening of mitochondrial KATP channels and cardioprotection due to myocardial generation of reactive auxin species. So there are several pro-kinase which are activated, which also ends at the same point, that is activating the potassium ATP channels of mitochondria. Reactive auxin species are released. Then pro-survival kinase such as AKT and ERK12 also appears to contribute in ischemic preconditioning protection at the time of reperfusion, termed reperfusion injury salvage kinase pathway. So not only it protects against ischemia, it also protects against the reperfusion injury. So ischemic preconditioning it helps, and it also helps in salvage during reperfusion injury. Okay, then we have an alternative cardioprotective signaling pathway recruited at the time of the reperfusion. This is again under investigation. This is survivor activating factor enhancement pathway. We call it SAFE pathway, survivor activating factor enhancement pathway. This cascade involves tumor necrosis factor alpha and JAK-STAT3 pathway and terminates the permeability of mitochondrium, right? And what does it cause? Again, the level of calcium etc. inside the mitochondrium is less, and this confers the protection. Then we have in it all this pathway, lead to ultimately inhibition of MPTP opening. MPTP is a non-specific channel on inner mitochondrial membrane, right? And it has been proposed that common pathway for ischemic preconditioning, PK, the protein kinase C activation and mitochondrial KATP channel opening to protect myocardium occurs via this MPTP channel opening during reperfusion, thereby preventing the uncoupling of this mitochondria. So this inhibition of MPTP channel is the final pathway, and most of the pathway converge on this. So this is a non-specific channel that opens during the first few minutes of post-ischemic reperfusion. If we close this channel, then this apoptotic and necrotic damage to the myocardial cell will be prevented. So this is critical determinant of both apoptotic and necrotic cell death in the setting of ischemic reperfusion injury. Inhibition of the MPTP opening with ischemic preconditioning is believed to be mediated by activation of pro-survival kinase. Remember. So this MPTP is the final pathway. So if I show you